Welcome back, fellow mitochondriacs. I have an announcement to make, and that is I am presenting the first part of the first podcast on this channel, and it was with Professor Thomas Seyfried. And I will say that he is a gentleman as well as a scholar, and he was extremely down to earth and easy to talk to. And I really hope that you will get value from this sit down interview. I tried to take feedback from some of the members and some of the clients that I've seen in consultation to ask some very specific questions. And I really hope that this type of conversation is useful to you, enjoyable for you, and helps push our field of treating cancers and metabolic disease even further. So, without further ado, let's get into part one. Well, I'd like to introduce our first podcast guest, Professor Thomas Seyfried. And I'd just like to say thank you for coming on. And it's an honor to have you. And I hope we have a good discussion.
Oh, thank you very much. It's nice to be here today.
Yes, sir. So, when do you think that you had the epiphany or the kind of aha moment that cancer is truly a mitochondrial metabolic disease?
Uh, when we did, I published our paper in 2002 with my associate, Dr. Purna Mukherjee, who's still here working with me, and then the '03 paper in British Journal of Cancer, when we were able to clearly link the levels of sugar in the blood with how fast the tumors could grow and the anti-angiogenic, anti-inflammatory, pro-apoptotic actions of calorie restriction, which is comparable to water-only fasting. And having just read Warburg's seminal paper once or twice, the connections were solid. But it took me another almost 25 years to know exactly where Warburg was correct and where he was not correct. And his understanding of the situation and the problems that he ran into in trying to convince others. So, but we just recently, in our research here at Boston College, provided the first evidence, hard evidence, that the amino acid glutamine is also fermented, which most of the field of cancer does not know about, nor did Warburg know about it. But it clears up a tremendous amount of confusion that was associated with Warburg's central hypothesis. We also showed unambiguously, our work provided with others, that oxygen consumption in tumor cells is largely independent of energy production through oxidative phosphorylation, which led many people to question Warburg at the beginning, showing that many tumor cells consume oxygen just as avidly as normal cells, thereby saying Warburg was wrong. And Warburg tried to say that it wasn't wrong. It's just that tumor cells have such a powerful glycolysis that the presence of their OXPHOS was unable to put it out. But we have clearly shown that OXPHOS is neither necessary nor sufficient for driving the dysregulated growth, whereas the fermentation of glucose and glutamine are both necessary and sufficient. And tumor cells cannot burn ketone bodies or fatty acids. So this then puts everything back on track. Cancer is not as complicated as people made it out to be. It's driven by a fermentation metabolism. Without glucose and glutamine, no tumor cell can survive for very long. And they're not flexible. They're not capable of great flexibility. They're locked into an ancient fermentation pathway and cannot switch to other metabolites that will replace glucose and glutamine. So once you know that, you have the scientific evidence to support that, then what is standing in the way of dropping cancer deaths and treating people more respectfully and humanely with the new knowledge of what we have? So clearly there's something other than the basic science that's preventing the transformation of the way we treat cancer patients. And it has nothing to do with the science. It has largely to do with the profits. The profits. It's something outside the scientific zone. So, but in the end, the science will win. You can only deny the science for so long. And we're starting case reports, and we're seeing people now that if you, but right now, no one, Thomas Duryea and I wrote all these papers. No one has yet designed a clinical trial doing exactly what we want them to do. The standards of care, which should always be flexible, are written in granite, which are immovable forces that prevent the full power of metabolic therapy to do its job. We use standards of care, but they have to be used strategically, not as an upfront treatment, but as a downstream effect to polish off any few surviving tumor cells used in very different modified ways, which the field is very resistant against. The medical people going through medical schools aren't trained to know anything about the biochemistry and biology of cancer other than that it's a genetic disease. So you have all these obstructions in the way of moving the field rapidly forward, dropping the cancer death rate massively, doing this. Not only cancer, but a lot of other chronic diseases as well.
Yes,
It's a
sir.
mitochondrial metabolic disease driven by a fermentation metabolism, which can be so easily targeted relative to what we're doing with an outcome that will be astonishing. But all these other things stand in the way. We have done the science. We have interrogated what these tumor cells can use and what they cannot use. We're developing really, really sophisticated, beautiful ways to treat high-grade gliomas in children, pediatric high-grade glioma, with really powerful results that will not be used in the clinics because it doesn't involve radiation or chemo, the types of chemo that are presently being used. So unfortunately, we must sacrifice all these little kids unnecessarily, which is a heartbreaker. So we see all this that we're, and we will. It's just a matter of time. The young physicians are interested in this. They're starting to unshackle themselves from the previous dogma, and they want to see good by their patients, and they will slowly make the change. But right now, we're doing all we can to force the paradigm change.
Yeah, no, I think everybody from who watches this channel appreciates that like from the bottom of their heart. There's no question. And there is an explosion of cancer. It seems to be happening. That's definitely what, at least in part, motivated me because I have to be the one who, when someone comes into with abdominal pain and they get a CT of their abdomen and pelvis, be the one that tell them that they have likely metastatic cancer for the first time. And it's always hard telling someone that, but when it's someone who's young, like you're talking about these kids with, I don't do kids. I'm an adult internal medicine doctor, but when it's a young adult and they got, metastatic cancer, it just makes it a whole layer worse to
Mhm.
having that conversation. Um, I did notice in your most recent paper and the one that was published in April of 2025, which I am doing a whole video series on because it's such a great paper. You guys are trying to get away from using the word Warburg effect. And I was just trying to figure out why that was.
It's ambiguous. It was just, it was coined by Ephraim Racker at Cornell University as kind of a offshoot of the Pasteur effect. The Pasteur effect is the situation, which is very complicated biochemically, why oxygen shuts down fermentation in yeast. Yeast cells will ferment when oxygen is not available, but the yeast evolved to have that capacity. A yeast cell is equally comfortable fermenting as it is respiring. Although, as Warburg said, they can only ferment for so long, and when you start to respire again, there's a whole new generation of life that comes back into the organism. But the Pasteur effect is the suppression of fermentation by oxygen. So Racker said, well, the Warburg effect is the continual fermentation of lactic acid in the presence of oxygen. But there's a lot of complications behind that. What do you mean? Um, because we have what is the fermentation mechanism actually involve? It's a substrate level phosphorylation.
Correct.
It's the movement of a phosphate group from an organic substrate onto ADP to form ATP, and that's usually part of the payoff phase of the Embden-Meyerhoff-Parnes pathway. Um, um, and that seems to persist actively even in the presence of oxygen. And Warburg attributed that to dysfunctional mitochondria. The reason why they continue to do that is because they don't have effective oxidative phosphorylation. But the field argued against that because they said, no, that can't be because the tumor cells are consuming oxygen at the same, some tumor, not all, at a rate similar to that of normal cells. Because the field assumed that oxygen consumption was an accurate biomarker for ATP production through oxidative phosphorylation. Warburg said the same thing. He said 1 mole of oxygen consumed equals 7 moles of ATP,
Hmm.
whereas 1 mole of lactic acid produced is 1 mole of ATP. So 1 mole of oxygen, 7 moles of ATP. 1 mole of lactate produced 1 mole of ATP. All that's wrong. We have shown that those estimates are no longer correct because oxygen consumption in a cancer cell is used to produce reactive oxygen species and drive other oxygen-demanding reactions independent of oxidative phosphorylation. Well, where's the ATP? I can see ATP coming out of the mitochondria when they take in oxygen. Only if they have glutamine in the media, and that glutamine is being fermented through mitochondrial substrate level phosphorylation, which is a second form of energy inside the mitochondria, which is really remarkable. So we teamed up with the world leader on mitochondrial substrate level phosphorylation, Christos Xenopoulos from Semmelweis University in Budapest, Hungary. So Christos has been working on that pathway for decades. And then I brought it to his attention that we think cancer cells are doing a very powerful pathway. It's called the glutaminolysis pathway. Most of the people in the field thought glutamine was being respired. It was anaplerotic, which is the feeding of carbons into the TCA cycle. No, 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 no. They're using the waste product of glutaminolysis is succinic acid. It's a waste product, just like lactic acid is the waste product of cytosolic substrate level phosphorylation. Succinic acid is the waste product of mitochondrial substrate level phosphorylation in the glutaminolysis pathway. So when I told people on the web that cancer cells have been telling us for decades what they're using to stay alive and grow, because they're throwing out waste products telling us exactly the pathways that they're using. So when you see succinic acid and lactic acid in cancer, and you always see it, you know immediately that they're fermenting and that this acidification is blocking like chemo and radiation, all the things they're so tough, they're hardy, they're all this kind of crap. I said, because they're fermenting. If you take away the fermentable fuels, they become remarkably vulnerable to the lowest doses of chemo and radiation. They're weak. They're already on the weak.
In fact, it's the lactic acid and the succinic acid tumor microenvironment that leads the chemotherapy not to be able to get into the cancer cell, correct? It gets eaten up by the acidic microenvironment.
Yeah, it creates a wall of
Yes.
acidification around the tumor cell. And they say, oh, we're doing everything to figure out how immunotherapies and radiation and chemo, that doesn't work. They're so powerful. Yeah, because they're crapping out acidic molecules that all you have to do is pull a plug on the glucose and glutamine, and their protective shield disappears, and they die. And now that what's ever left is extremely vulnerable to the lowest doses of chemo or anything else you want to do. You throw in a little exercise on top of that, and man, these damn things are getting hammered. And you don't have to cause permanent damage to people. This is stupid because the people, once you understand the biology and biochemistry of the adversary, you know how to cleanly manage it. And
Right.
the problem is nobody's listening or understanding. I don't know. Do I speak in some sort of foreign language that no one can understand what the hell I'm saying? Is this language, what I just shared with you, so incomprehensible? Is it like Einstein's theory of relativity? What is going on here?
For me, no, but that's only because I love biochemistry and I've studied it. But I think that at least clinicians, I'll speak for many of my colleagues, generally being very frank, we learn the biochemistry we need to pass our boards. And then once we get into clinical medicine, we just forget about it. Like as if it's
Yeah,
not important.
I think they need to retrain you guys. I think we should stop wasting time on a bunch of bullshit that has no relevance to the clinical practice, which a lot of it is misinformation in the first place, asking you people to rote memorize stuff. once you get into the cancer clinic, you should do all your clinical practices with minimal basic science. And then once you get into your specific field, roll in the basic science to be parallel exactly with the clinical practice that you're doing. So
Agreed.
that whole field needs to be reevaluated
I
and
don't disagree.
restructured.
I think one of the biggest fears that people have is that they're now aware of the cancer stem cell. And there is, as with some of the things that I'll ask you later, there is, I think, an intentional muddying of the waters or just frankly like misinformation
Mhm.
because they're trying to say that these cancer stem cells are in the most hypoxic regions of the tumor. And then they're trying to argue that they're using oxphos. Do cancer stem cells use substrate level phosphorylation?
Yes,
Of course.
we published it. We have cancer stem cells and we have metastatic cells. Cancer stem cells cannot metastasize. They don't have the biology to metastasize. I published, listen to this. My most highly cited paper is the paper we published on the origin of metastatic cancer. It's been cited over 1,600 times. And of those 1,600 citations, about 5 people actually read the paper. They cite it because I said one thing: metastatic cancer is largely responsible for the death of patients. That's all they cited for. And then they go on and talk about
That's not
cancer
very
stem.
novel.
I find that you think all these smart guys at the top medical schools, they know what they're doing. They just parrot what everybody else is doing. They all follow each other. They all say, "Oh, we have innovative work." You don't have any innovative work. We got 1,700 people a day dying from cancer, for Christ's sake. What innovation do you have down there
Yeah,
that's
I
making a
know.
difference? Zero, right? Give me a break. 70 people an hour. Oh, I have a lot of Do you know some guy down is telling me I just got $6 million from the NIH to study this signaling pathway. I said, so what? You tell me how many people are going to stay alive because you understand that signaling pathway. We spend
Right.
$6 billion for something that has no relevance in the
You know
clinic.
what's interesting, Dr. or Professor Seyfried, is that most of those signaling pathways, what do? They upregulate glucose and glutamine.
I know. Yeah, run by HIF and MIC,
I know.
oncogenes. The oncogenes are facilitators opening the floodgates for the fermentation
100%.
fuel.
100%.
All right. So I just shut down on we physicians are masters at changing diets and lifestyles to reduce the levels of glucose and glutamine. And we have to come in with drugs. We found these parasite medications. So I did a dive on this. And it turns out that parasites, when they proliferate, they use a little bit of oxphos, but when they stop proliferating and enter into residency in the tissues, they start fermenting. And the way they energy is mitochondrial substrate level phosphorylation using glutamine. So I'm saying, whoa. So if I take a drug that's known to kill parasites like M-bendazole, fenbendazole, why don't we put that together with calorie restricted ketogenic diets and a few other things? And boy, I'll tell you, knock the crap out of these tumor cells. But you can't use it because you can't make any money on M-bendazole. It's all money, revenue
Right.
generation.
Well,
So
people are
we sacrifice the cancer patients for the good
right.
of the revenue.
People, despite that, are doing it behind the scenes without any guidance because no
Yeah,
one is willing to help them. I have a
yeah.
question. I read your paper that talked about, I think you guys were the ones who discovered that menbendazole blocks GLS similar to that of Don.
It has a minor effect. It's not nearly as powerful as
Not
Dawn.
near. Okay, I was going to ask
Okay,
you, like, what degree is
and the
it?
Chinese and people from India and China, a long time ago, because the Indians had done a lot of work on the action of parasites, because almost everybody in India takes parasite medications.
Right.
So they did a lot of work on that. And they knew it blocked glucose uptake. That was one of the mechanisms. But
Correct.
they didn't know that our paper under review right now, or in work, and we have a bioarchives on it, where we suggested for the first time that embendazole may also be targeting the glutaminolysis pathway. So we saw glutaminase go down with embendazole. So clearly it's having some push on both of those pathways. But by itself, it's not going to be the big hammer. But it
Right.
certainly can be a push in the right direction, mainly because it's non-toxic. You
Right.
don't have to worry about going bald and having your gut blown to hell. But one more thing that I didn't put in the new paper in April that has come to my attention very recently about the succinic acid. And this comes back to metastasis. First of all, cancer stem cells cannot metastasize. Metastasis happens when the myeloid cell, whether a macrophage or another leukocyte, fuses with a stem cell, creating a hybrid cell that now has the biology biology and biochemistry to invade, disseminate through the bloodstream and set up secondary satellites through a metastatic process. All of this is a very sophisticated biology that we have studied in the field of glycobiology, where I worked for decades, how these various glycolipids and glycoproteins are upregulated to allow macrophages, monocytes, to move out of the bloodstream into an area of infection or inflammation. The metastatic cell is half macrophage. It has abnormal mitochondria, but it has the proliferative capacity of the stem cell in the shell of a macrophage. This was done by John Powlick years ago and many others. They just choose to ignore all that information. The issue is, one of the key things about metastatic cancer is they seem to be they're immunosuppressive and resistant to immune attack. Well, guess what? People will say, well, how come? I can understand why the acidification protects a solid tumor in a particular tissue, but when these things get out into the bloodstream, how come our immune system doesn't kill them? Succinic acid is a powerful immunosuppressant. It's succinic acid being crapped out of the metastatic cell is like a paralysis to our immune system, because it's a macrophage. Macrophages are powerfully immunosuppressant, like in some cases. So we're putting all the biological facts together, making it very clear. So when we found out, what do macrophages eat? What is driving them? Glutamine is a powerful fuel. So, but you have to be careful now, because now comes in your clinical experience. If you're too aggressive in targeting glutamine, you not only damage your immune system, but you damage your gut. The gut is a big utilizer of glutamine. So that's why we developed the press pulse. You can press glucose, but you pulse glutamine targeting.
Can I push back a little bit, doctor? Is that okay? Or professor? So I of course I've seen the beautiful classic graphic that you have, and then the new one that you came out in December of 2025, and it's also beautiful. But this is a couple of pieces of information that I wanted to put in your ear. Number one, there was a paper that I read, and I have to pull it to tell you exactly what it was called. But they showed when you restricted glutamine, there was a paradoxical immune improvement. Number one, that they didn't expect. Number two, there were papers that were done on Dawn. There was a wonderful paper that was published. It was called like "We're Not Dawn Yet" in 2018.
Yeah, I know that. Yeah.
And it said, and if you looked at the trials that had the best clinical outcome, it was ones that were given a daily dose of Dawn. And then the third piece of information I wanted to put was there was also another paper that was done. It was a phase 1 or 2 clinical trial for GBM. And they were using mebendazole plus the standard of care, not mebendazole plus keto, not mebendazole plus anything else, but it was just mebendazole plus standard of care. And it showed that they increased the life expectancy of these GBM patients by like 6 or 8 months, which was like not quite double what the standard of care was giving. And they were giving mebendazole daily, every single day. And you're saying that we know that from your work that they have a glutamine inhibition. Maybe it's not as strong as Dawn.
Yeah.
But it just seems like maybe that glutamine can be maybe not completely pressed down, but to some degree pressed down more chronically without adverse effects. Maybe. What do you think about that?
Well, we tested a lot of that, and if you look at the Not Done Yet paper, which was really really good, and some of the others, Barbara Schlusser at Johns Hopkins is doing this work. She's done some really nice work on this, because they're trying to they don't want to use Dawn because you can't make any money on it.
Correct.
So that seems to be the driving force for what can or cannot be used. So they're using DRP 104, Judon. They have different varieties and structures of these things. But some of the control groups in those papers were not included completely. I'm not saying I think those drugs they're working on will be very valuable, but what they never do is they never target glucose at the same time.
Correct. Never.
When they're doing this, because the whole strategy of ketogenic metabolic therapy is a strategic attack on the whole, improving the whole physiology of the patient while specifically degrading the tumors to capacities.
Right.
You're never going to get, I don't want to say never, but you're rarely going to get optimal therapeutic outcome if you're only targeting one of the two pathways. Although I'm shocked at some people who are living very, very long by targeting just the glucose pathway for sure. But getting back specifically to those kinds of studies, they're always incomplete. As I said to you, none of them are doing what we think needs to be done.
No,
And as far as the uh, protection of the gut, the reason why Don was not used clinically is because of its tremendous damage to the gut, mucocytosis. It was doing a lot of the same things other chemo was doing,
correct.
but they were not targeting glucose at the same time. They were giving high dosage continuously, and they were creating all kinds of problems. So clearly, we need to spare the gut, and we need to spare our immune system. As a physician, you should know that people who are burned, uh, um, their skin is open now to attack by skin bacteria, staph, and strep. And many cases, when burn patients are given high dose glutamine as a therapy to ward off or the infection, mainly because our immune system is dependent on high dose of glutamine. And that gives the strength to the immune system to battle and use the respiratory burst, the way you kill bacteria. All of this is linked in one way or another to the glutamine metabolism. Otherwise, your patient's going to die.
Correct.
So if you're using a drug like Don continuously, which is a real powerful glutamine inhibitor, yeah, you're going to kill tumor cells massively, but you're also going to make the body vulnerable to immune system failure and gut damage, and you're back to square one again. So the bottom line is that you've got to strategically target the glutamine. You can hold a chokehold on that glucose because it's a non-essential metabolite. The only cells that well, I don't say the only, but the cells that require glucose are the erythrocytes. They don't have a mitochondria. And they
Correct.
don't. They need, but they need tiny amounts of glucose. And some of our brain cells can use some small. Don't forget, the brain will suck out the majority of glucose that's in your body. You do a little exercise on top of that while you're in therapeutic ketosis, and then you sprinkle in a little bit of embendazole. Our cocktail now consists of Don, embendazole, and CPI 613. CPI 613 is a drug that blocks the alpha ketoglutarate dehydrogenase in the TCA cycle.
Mm,
However, it was used in the clinics for pancreatic cancer, and it was a bust. It was too toxic. So we have the drug, and interestingly enough, we tested it alone in our cancer model, metastatic. It was too toxic for sure. So my colleague, Dr. Mukherjee, we found out that when you administer low dose and ketogenic diet, it becomes far less toxic, and it has very powerful therapeutic efficacy. And then the ketogenic transition to therapeutic ketosis allows us to use these toxic drugs in much lower dosages and still maintain the power of their therapeutic efficacy. This is a new world. This is a completely new world on how to manage cancer. We can slay the beast with minimal collateral toxicity once the clinicians understand the power and wielding the power of metabolism and nutrition to work with the patients. Right now, it's our way or the highway, and the patients don't really have any major input into the management of their disease. When the new paradigm comes, the patient will be the most active participant, following the guidelines of a knowledgeable oncologist or physician. Anyone who understands this will be able to manage these cancers. And we never use the term cure in our world here. We use the term successful management. What does that mean? Well, it means that you're alive when you should have been dead, but we don't know if you're going to ultimately be no evidence of disease for the rest of your life. I don't know that. This is all new. All we know is that we can keep terminal cancer patients alive for longer, far longer than what was predicted based on the establishment's understanding of the situation. So, and more physicians are always miffed. One of the things that kills me as a non-physician is the comments, because I get hundreds and hundreds of comments back from the cancer patients that are using metabolic therapy. And when
hmm
they approach the oncologist or the physicians, um, oftentimes the physician will say, wow, I've never seen anything like this. I don't know what you're doing, but just keep on doing it. And I'm saying to myself, don't you guys want to know? Aren't you
There's a
interested?
there is a general lack of curiosity in medicine. I don't know if it's that because it doesn't go along with the dogma, or if it is just because we're so overwhelmed with a bunch of sick patients that we don't have time to ask the questions, but there is just a general lack of curiosity. And it frustrates me beyond belief, but
Well,
I see that.
don't forget, my job here at Boston College, half of the students that I teach are pre-med kids that all go on to become physicians, and they're all focused on getting the highest grade rather than really understanding the information. They must have huge hippocampus to memorize all this kind of stuff. Um, and then they just regurgitate it, and they practice these MCAS tests. And they're all like what do they call them, super kinds of students, high octane kinds of students. They're always like memorizing stuff. They're always working hard to get the highest grade in the class, competing
Right.
with everybody else. And I think the selection of those kinds of people may rule out curiosity. I don't think some B students would make poor physicians. I think sometimes those kids might have a greater level of curiosity because we select for the kinds of people that can enter the medical schools. And it's very hard for people to get into medical school. They have to have super high grades. They have to do all these tests. And I think we select for the wrong kinds of people. Not to say that all physicians are like that, for sure not.
Could be.
But they're not being allowed to think creatively. They just do what they're told to do, and they do it in a very efficient manner. And they've been doing that since the time they were freshmen in college.
Very military like, very
Yeah, yeah.
shine your
They
boots.
they
Yeah.
rarely challenge the status
Well,
quo.
yeah, to be honest with you, we we are it almost is in some cases, especially like in the surgical specialties, like it is like a boot camp, like the attending is the drill sergeant and you are just this, peon,
Yeah,
and just don't speak up and just don't let anybody notice you and don't ask questions, and like
yeah,
whatever he says is God. And that's the way it is, and
yeah.
that is the training, in some
Yeah,
ways. I
well,
think
that I think for uh, 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 certain skills, surgeons, they need to do that. They need to have that discipline. But for chronic disease management, which is basically crippling the entire nation,
100%.
you have to have a new view on how to manage these diseases, which is very different from the kinds of training you're getting.
Right.
We know how to manage chronic. We have some big papers that'll be coming out in the near future that are going to deal with this, not only cancer, but all these chronic diseases in a very effective way, identifying every major chronic disease as some form of mitochondrial dysfunction.
Do you know about Dr. Doug Wallace at the Children's Hospital of Philadelphia
Yeah,
and his
he's
mitochondrial heteroplasmy graphs and stuff like that?
yeah,
It looks so similar to what you guys publish, like with your like diminishing
yeah,
oxphos and your increasing SLP with as
yeah,
mitochondrial dysfunction, and the just how every paper you guys put out is like a newer beautiful graphic, but there's like the mitochondrial cristae are all beautiful and then it becomes less beautiful and less beautiful, and obviously that's showing a diminishment in bioenergetic decline that Wallace talks about with his stuff too. And I just thought that was such an interesting intersection
yeah. Well, I don't
science.
know. I don't know Wallace personally, although I've met him at meetings. But he's heavily focused on mitochondrial DNA.
Right.
And recognize. And in my book on cancer as a metabolic disease, he was one of the first to say cancer is death. Well, not the first. Clearly, Warburg had said that, but he deviated from that, focusing more attention on mitochondrial DNA. In fact, that's how we actually get started. My former student, Mike Kibish, who's now a senior scientist with Berg, a big pharmaceutical company. Um, when we didn't know uh, uh, at the beginning how important mitochondrial DNA was to the origin of cancer. So we took my five mouse models of cancer, each one derived independently from the other, some spontaneous, some chemically induced. And we isolated and purified. First, we isolated the mitochondria because a lot of people study mitochondrial DNA by using SNPs of mitochondrial DNA amplifying the material between the two coding regions to amplify the middle piece. Uh, And then they look at that. But over hundreds of millions of years of evolution, bits and pieces of mitochondrial DNA have seeded into the nuclear genome. So by using SNPs of mitochondrial DNA, you may amplify what we call pseudogenes in the nuclear genome, giving you misinformation. So what we did, Kibish did, we isolated and purified the mitochondria directly out of the tumors themselves, highly, highly purified mitochondria. And then we isolated the DNA from the mitochondria of the tumor cells. And then we sequenced every single base in the we actually changed the mouse mitochondrial genome by one base because they made a mistake. We actually sequenced the entire mitochondrial genome in 5 independently derived tumors, and we found not one single pathogenic mutation in any one of these 5.
Interesting.
Yeah, and my a colleague, or not a colleague, but an acquaintance, Eric Schoen from Columbia University, who's a mitochondrial guru. He had found tumors with no mitochondrial mutation. He knew I was right, so because he had seen the same thing. Now, and don't forget heteroplasmy. We did find in one of our tumors there was some heteroplasmy, but no mutation in any one of the coding regions. So other people came out. Cruz Bermudez, you should look at this. It's a beautiful paper. They found different mutations in mitochondrial genomes. Like us, they found some that had no they had mutations, but they were not in coding regions of the mitochondrial genome.
So it wasn't
But
it
they
wasn't oxphos proteins. It wasn't one of the 13 proteins that encode oxphos.
Well, it was if you get one of those and it's not completely knocked out, you can get neoplasia. But if it's completely knocked out, you don't get neoplasia.
Because
So
you'd
there was
probably rupture the mitochondrial membrane and you would
yeah,
get
yeah.
apoptosis.
So yeah, it was very interesting. If you had no mitochondrial DNA, you got no neoplasia. If you had perfectly clean mitochondrial DNA, you don't get neoplasia. But you could only get neoplasia when there was partial disruption of proteins of the electron transport
But
chain.
that totally makes sense, doesn't it? Because then they're leaking electrons, then you have
Yeah,
more ROS and then
yeah.
damage to mitochondrial membranes, right? I mean, like,
Yes, and not only that, it gives the cell an opportunity to transition to fermentation. So don't forget, it's the two-step process.
correct.
And then we went in, and you find out that there are certain cells in our body that rarely, if ever, perform cancer. And those are mature cardiac myocytes and
Neurons,
neurons of the central
correct.
nervous system. They cannot ever transition to fermentation. So they can't become cancerous. They up and die, like Parkinson's disease. You have mitochondrial dysfunction in Parkinson's disease, but rather than transforming into neoplasia, the cells die.
Right.
So you have dead cells. And same with heart cardiomyocytes. You can't get cancer from these cells because their demand for oxphos energy is so high that they can never transition to fermentation for a protracted period of time. This was another clue that we got for the mitochondrial substrate level phosphorylation using glutamine as the substrate. During heart attacks, the bloodstream fills up with lactic acid and
True.
succinic acid. The succinic acid, the guys in the cardiac field knew about this a lot, but apparently the people in oncology and cardiovascular disease don't ever talk to each other. They might as well be on different planets because we have known for a long time that when during heart attacks, succinic acid and lactic acid build up tremendously in the bloodstream. And if you don't bring oxygen back into that person in a short period of time, you're going to be dead from neuronal
Right.
damage.
Well, the
But then
same
as
thing
soon as,
happens
but
though. The
as
same thing
soon as
happens in sepsis, right? Sepsis, any kind of hypoperfusion disorder, we can
yeah,
detect lactic acid, serum lactic acid, and it'll change the pH.
yeah,
This is the question though. We know that the pH around the tumors are about 6 to 6.5, but we don't see serum lactic acid in these cancer patients, even metastatic cancer patients. I check it a
yeah,
lot, for various reasons. And
yeah.
is it getting eaten up by reverse Warburg or where is it
No,
going?
no, it's going to the liver, convert it back through the Cori cycle, come
Got
back
it.
to glucose, comes back as glucose. There's a few patient papers you can read in blood cancers where patient died from lactic acidosis. So I read a couple of those where the number of blood cancer cells was so high that the lactic acid in the bloodstream
Interesting.
was
No, actually,
overwhelming.
now I'm thinking about it, Professor. I actually had a case of a guy. He had this unexplained lactic acidosis. No one could figure it out. He ended up having a non-solid tumor.
Yeah. Well, there's a couple of reports in the journal Blood and the journal Circulation where they've spoken about these kinds of cases. But you're right with metastatic cancer. That's the Cori cycle, where just like when we exercise a lot, the lactic acid
Right.
produced in the muscle is going to the liver and being converted back in through gluconeogenesis back into glucose. So the cancer cell and the wasting away of your muscles releases tremendous amounts of glutamine, which is part of the cachectic
Right.
cascade. So the glucose glutamine, you waste away, cachexia. And people always say in the clinics, oh, don't do fasting or ketogenic, you're going to lose weight. And I said, why? Because, well, the cachexic patient is losing weight. That's pathological weight loss as opposed to therapeutic
Correct.
weight loss. You got to, everything has to be reevaluated. And I always find that, just to share with you, in biology, we know structure determines function. This is one of the
Correct.
foundational principles. This applies to all areas of biology except oncology. The oncologists have no clue. They can see a broken mitochondria with no cristae and say it's working perfectly well. Just like you said, they're doing oxphos and hypoxia.
Correct it. It doesn't make any sense, does it? I mean,
Right. No,
how
it
do you
makes
have it in the
no
same
sense.
sentence? It doesn't make any sense.
I know. Well, how do you think I feel when my students and I read
I
all
know.
this stuff?
That concludes part one. I hope that it was useful to you, enjoyable, and I hope you come back for the second part of the interview, which is slightly longer, next week, and continue to learn from this fruitful conversation between Professor Seyfried and myself. If you like videos like this, please like, share, and subscribe. And until next time.